Hey guys, today we're going to talk about Chapter 16, Nursing Management During the Postpartum Period. We already talked a little bit about some of this last Friday when we talked about postpartum complications, but Chapter 16 focuses more on when there are not complications present, how do we take care of postpartum moms? What I want you guys to really take away from this chapter is that motherhood really can be special, but the postpartum time is a time of huge major adjustments and adaptations for all family members. From the outside looking in, maybe it doesn't look like that, but truly there are so many adjustments being made by the woman, by the dad, by the siblings. Every part of their family is being affected by the birth of this new baby. So we really need to take that into account when we're doing our assessments and our nursing care. Physically, after the birth of the baby, it can take several weeks for a mom's baby to return to its pre-pregnant state. We need to be aware of the changes that happen in that postpartum period so that we can make our observations and assessments to either validate that normal changes are happening or if there are any deviations from the norm that we need to address. So our nursing management for postpartum women focuses on two things: the woman's ability to adapt to the physiologic changes and also to the psychological changes happening. And then again, based on those assessment findings, we will implement the plan of care to address any particular needs that that family has. So our nursing assessment begins within an hour after the woman gives birth and continues through discharge. Our postpartum assessment includes three things: vital signs, physical assessment, psychosocial assessment. After the birth, our postpartum assessments are typically performed every 15 minutes for the first hour, every 30 minutes for the second hour. And that's not a full assessment. That's vital signs, a fundal assessment, a lochia assessment, and a pain assessment. So that's just our focus assessments that are every 15 minutes and then every 30. And then every 4 hours for the first 24, and then after that, every 8 hours. So what I want you to know is during the first hour, we're doing our vital signs and our focused assessment every 15 minutes, and then every 30 minutes during the second hour. Things that are danger signs are fever, foul-smelling lochia, or an unexpected color or amount, large blood clots, or bleeding that saturates a pad in an hour, severe headache or visual changes, calf pain, swelling, redness, or discharge at the site of an episiotomy, epidural, or abdominal incision, dysuria, burning, or incomplete emptying of the bladder. That will lead you to believe there is potentially a UTI. And then shortness of breath or difficulty breathing, which would be signs of a potential pulmonary embolus, and depression or extreme mood swings. So when you think about the complications that we talked about last week, the major complications are postpartum hemorrhage, thromboembolism, postpartum depression, and a postpartum infection. So these danger signs address those four main complications. When we're doing our postpartum assessment, remember back to our bubble E that you guys learned about last week. First, we're going to assess the breast, then the uterus, the bowels, lochia, episiotomy, extremities, and emotional status. Not exactly in that order, but that acronym will help you remember. Vital signs: temperature might be slightly elevated during the first 24 hours, related to dehydration and potentially related to an epidural. Epidurals can cause an increased temperature. So can multiple doses of Cytotec. Pulse, a rate of 60 to 80 is normal during the first week after birth. Respiratory rate should be the same as a non-pregnant person. Blood pressure Really shouldn't change a whole lot, but be alert for kind of swings both ways. So orthostatic hypotension, and then also gestational hypertension and preeclampsia. Preeclampsia typically is cured at delivery, but it can present postpartum in rare cases. So just kind of be on alert for that. If your patient was normotensive her whole pregnancy and labor, now all of a sudden she's hypertensive, that warrants a little bit of investigating. And then pain. So our goal is a pain score of 2 or less at all times. When we're assessing the breasts, we're going to inspect for size, contour, symmetry, engorgement, check the nipples for cracks, redness, or bleeding. And then we want to make sure and note if they're flat or inverted. Cracked or blistered and bleeding nipples usually indicate that the baby does not have a correct latch when it's nursing. I don't really look at everybody's breasts. I just ask them I ask them how breastfeeding is going. I ask them if they're having any pain or cracked or bleeding nipples. If they do, then we need to address the improper latch. But normal findings would be not cracked, not blistered, no engorgement, no erythema. The uterus, we're going to assess the fundus. It should be firm. Make sure you have the woman empty her bladder before you assess the fundus. We're going to use a two-handed approach with her in the supine position and the bed flat. And then gently palpate the abdomen, feeling for the top of the uterus, while your other hand is on the lower segment of the uterus to stabilize that. I'll show you a picture on the next slide. But the fundus should be firm, so it should feel like a hard ball, and it should be midline, right in the middle. After you find the fundus, you're going to place your index finger on the fundus and count the number of finger breadths between the fundus and the umbilicus. 1 finger breadth equals 1 centimeter. So when we document and report that, if we had 2 finger breadths between the fundus and the umbilicus, we would report that as the fundus is 2 below the umbilicus. Usually 1 to 2 hours after birth, the fundus is typically between the umbilicus and the symphysis pubis. 6 to 12 hours, it's usually at the level of the umbilicus, and then progresses downward at a rate of 1 centimeter per day. So this picture shows you how you're going to be palpating the fundus. See, her lower hand is supporting the lower segment of the uterus, and then with her other hand, she's palpating right by the umbilicus, just pushing down until she feels the firm fundus, and then making note of where it is in relation to the umbilicus. Women typically diurese within 12 hours after childbirth, and that will continue for several days. They need to get rid of all the extra fluid that they got maybe during labor, and also all that extra fluid from the increased blood volume that they had during pregnancy. Urinary retention postpartum can lead to a UTI and also postpartum hemorrhage, like you guys learned about yesterday. So just assess the bladder for distension and make sure that she's emptying adequately. A lot of women will get constipated after birth, so we need to make sure and address any type of constipation or GI symptoms she's having. Potentially, she could take stool softeners for that, especially if she had a cesarean section and is on narcotics. So we're going to inspect the abdomen, auscultate bowel sounds, ask about passing gas, especially if they had a cesarean section. Lochia is just another word for bleeding, really, or the bloody discharge that women have after birth. When we assess the lochia, we assess for amount, color, and odor. Ask her how many pads she's used in the last 1 to 2 hours. She will bleed more when she breastfeeds because breastfeeding will cause contractions, which then empty the uterus of blood. If the uterus is boggy or if excessive bleeding, we need to massage the fundus until it's firm. Women who had C-sections do tend to have less lochia, and it's important for us to teach them what is normal and give them some anticipatory guidance that their bleeding should continue to decrease. It shouldn't be more than 1 saturating one pad in an hour, things like that. When we describe the lochia, we're describing it as scant, light, moderate, or heavy. Heavy would be a pad is saturated within 1 hour after changing it. That's abnormal. I don't routinely assess episiotomy or the perineum. I ask women about pain and tenderness. I ask them about any discharge or drainage. If they don't report anything abnormal, I don't look. If there was an infection at the episiotomy site or a hematoma in the perineum, that's the other thing we might be concerned about. Typically, they would have pain or other complaints. So I don't visually assess it, but I do ask questions to assess the episiotomy and the perineum. If your patient had an epidural, we should just assess the epidural site on their back, make sure that it's not bleeding, doesn't look infected, anything like that. You all know that pregnancy and postpartum is associated with an increased risk of VTE due to the hypercoagulability state of the mother during pregnancy. So we always need to be assessing for signs of PE and DVT, and then also encouraging ambulation. That's it for our physical assessment.